What if I told you that one of the most common conditions that affect women has been misunderstood for decades? And what you think you know about PCOS might actually be wrong. Here's what most people believe. PCOS is a reproductive issue. It's all about irregular periods, cysts on your ovaries, and maybe trouble getting pregnant. Now that is the conventional wisdom. It's what's been taught in medical schools for years. But in 2023, the world's leading experts on PCOS released landmark guidelines that completely rewrote the PCOS rulebook. And what they found was surprising. PCOS is not just about your ovaries. It's not even primarily about your ovaries. It's a lifelong full body condition that affects your metabolism, your heart health, and yes, your reproductive health too. But the name itself is actually misleading, and the way PCOS has been diagnosed all along has changed too. When the new guidelines dropped in 2023, it caused everyone to rethink their approach. So in today's video, I'm going to be breaking down the 4 most important and honestly quite surprising truths about PCOS that modern science has uncovered. These are most things that many doctors are themselves only learning about now. Because if you have PCOS, or if you think you might have PCOS, this information could completely change how you understand your body and how you get the care that you deserve. Okay, let's start with the name, Polycystic Ovarian Syndrome. The name itself is misleading. Stay with me. Because despite what the name suggests, you don't actually have to have cysts on your ovaries in order to be diagnosed with PCOS. I know it sounds crazy, it's literally in the name, but here's how it works. The most widely used diagnostic criteria for polycystic ovarian syndrome is the Rotterdam criteria. Now, there are some people who don't agree with this criteria, and they did discuss this going into the 2023 guidelines. But essentially, in order for you to diagnose PCOS, you only need 2 out of the 3 criteria that the Rotterdam criteria outlines. 1, irregular cycles or an absence of ovulation. 2, high androgen levels. Androgens are basically male type hormones. Even though women do have them, we have them at lower levels. There's 2 ways that this can be diagnosed. Either you have symptoms that suggest that your androgen levels are high, or your blood tests show that your androgen levels are high. And 3rd, the classic polycystic ovaries that are seen on ultrasound. So what this means is that you could have irregular periods or a lack of ovulation and high androgens and not have cysts on your ovaries and still be diagnosed with PCOS. Now, it gets even more interesting than that, because the idea of what polycystic actually means has also changed. For years, we used the cutoff of 12 cysts or follicles per ovary. That number has since increased to 20 per ovary. Now, that isn't because PCOS itself has changed. It's because our technology has gotten better. Modern ultrasound machines have gotten really good at spotting these immature follicles or cysts on the ovaries. Some of them that we couldn't actually see before. And that was actually causing a problem. Because here's the thing, having lots of cysts on your ovaries is actually a very common thing. Studies show that 20 to 30% of women in their reproductive years may have this appearance on their ovaries, but they don't have PCOS. One study found that up to half of women without PCOS met the 12 follicles per ovary threshold. So they were essentially diagnosing healthy women with a condition they didn't even have. So why does all this matter in the first place? Well, it's because it's forcing a fundamental shift in the way we think about PCOS. It really isn't about your ovaries at all. The cysts, or more accurately, the follicles that we see on ultrasound, are more like a sign kind of pointing you in one direction or another. The real issue is actually the underlying hormonal and metabolic dysfunction that happens in this condition. That's actually what's driving everything. And this brings me to the most important point about PCOS. Because once you actually understand what PCOS is doing to your body, and I mean your whole body, it changes everything. The risks are way bigger than many people even realize. And that's exactly what the research is now screaming at us to pay attention to. Here's what you need to understand. PCOS is not a gynecological issue that sometimes affects other things. It's a systematic, whole body, lifelong condition. And the potential risks are serious. For decades, PCOS was treated almost exclusively through the lens of reproductive health. Doctors focused on managing periods, helping with fertility, and dealing with acne and unwanted hair growth. But the 2023 guidelines make it crystal clear that this approach is dangerously incomplete. Women with PCOS are 5 to 10 times more likely to develop type 2 diabetes than women without the condition. That's a 5 to 10 times higher risk. They also have significantly higher rates of developing obstructive sleep apnea, and this is independent of body weight. So you can have a normal BMI but still be at increased risk. The risks of endometrial cancer also increase with PCOS before menopause. But here's what really struck me. The psychological burden of PCOS is so significant and so well established that the guidelines are now recommending that all adults and adolescents diagnosed with PCOS are screened for depression and anxiety. That's not just if they seem sad or anxious, and not just if they ask for help. This is everyone. And this is a profound shift. This is the medical community acknowledging that the mental impact and burden of PCOS is not just a secondary issue. It's not just about feeling upset because of your symptoms. It's a core feature of the condition that requires attention. And when you think about what women with PCOS are dealing with, the physical symptoms, the metabolic conditions, the way the condition affects your self-image and your identity, it makes complete sense that mental health would be impacted. The guidelines are finally catching up with what patients have been saying for years. This completely reframes PCOS. It's not just a period problem, and it's not something that you only think about when you're trying to get pregnant. It's a major public health concern that demands a multidisciplinary team, so lots of different practitioners coming together to manage this condition across the entire lifespan of every person with this condition. That means that your care team shouldn't just be your gynecologist. You may need an endocrinologist, a cardiologist, a mental health professional, a dietitian. You need a team that understands that managing PCOS means managing your metabolic risk, managing your heart health, managing your mental health, not just your reproductive system. Now, that's a lot of heavy information, but here's some genuinely good news. Advances in our understanding of PCOS aren't just about understanding the risks better. There are actual practical improvements in how we diagnose PCOS that have been made, because science is actually making the diagnosis of PCOS far more accessible. Remember, one of the Rotterdam criteria said that we need to identify lots of cysts or immature follicles on the ovary. Now, traditionally, that's done using what's called a transvaginal ultrasound, which is basically a probe that is inserted vaginally to have a closer look at the ovaries and identify those potential cysts or follicles. Now, for many women, this is not a big deal, but for others, whether we are talking about really young patients, those who've experienced trauma, or if you're just not comfortable with this type of invasive test, getting the scan done can be a real barrier to getting a diagnosis. Now, the 2023 guidelines are saying that for adults, a vaginal ultrasound may not be necessary. A blood test measuring anti-Müllerian hormone, or AMH, can be used as an alternative to ultrasound to identify those polycystic ovaries. How does this work? AMH is a blood test used to quantify how many eggs are in your ovaries. So all those little immature follicles or cysts on your ovaries produce AMH. So the more follicles you have, the higher your AMH will be. By measuring AMH in the blood, we can get an indication about whether or not you may have that polycystic appearance on your ovaries without needing to do an internal scan. This is a less invasive option. It could potentially save costs, and it's a more comfortable option than the internal ultrasound. Now, it's important to note that there are two caveats here. The first is that AMH cannot be used as a single test to diagnose polycystic ovarian syndrome. You must still assess all three criteria: irregular cycles, lack of ovulation, high androgens, and polycystic ovaries. AMH is just one tool in the toolkit. And second, this recommendation does not apply to adolescents. AMH levels are naturally higher during puberty, so that makes this test less reliable for teens. Also remember that you may still require an ultrasound if your doctor deems it necessary, and also to check things like the thickness of your uterus lining. And if an ultrasound is absolutely necessary, but the transvaginal ultrasound is not an option for you, then there is an option of doing the ultrasound via the lower abdomen. So in a similar way to how we would do a scan in pregnancy. But even with these two caveats, this is a really meaningful step forward because it means that diagnosis has become a lot more accessible. It also means that if you've been putting off being diagnosed because you're worried about the vaginal ultrasound, this may be an option for you because the earlier you're diagnosed, the earlier you can start managing this condition. Now, everything we've spoken about so far has been about rethinking PCOS on a clinical level. So how we diagnose it and how we understand its impact on your body. But cutting edge research is taking it even deeper, right down to a molecular level, to the very genes that may be putting you at risk for PCOS in the first place. This is where things get fascinating. Okay, so we need to talk about genetics, but not in the way that you might think. Emerging research on PCOS might involve something called epigenetics. Don't let the word scare you. I'm going to explain it because understanding this is really cool. Think about your DNA as a giant instruction manual for your whole body. Epigenetics is like having a series of switches that can switch on and off certain instructions without actually changing the instruction manual. One of the main ways this happens is with something known as DNA methylation. Think about it like this. Imagine having little tags, tiny molecular tags that are attached to your DNA that tell your genes to either, hey, be more active, or shh, be quiet. A groundbreaking study analyzed these little DNA tags, or the methylation processes. The genes that showed these epigenetic changes were the ones that were responsible for biological processes like how your fat is metabolized. More specifically, these were genes linked to cholesterol and diabetes risk. This is providing a potential explanation for all those metabolic risks that we talked about earlier. And it's connecting PCOS at a molecular level to an increased risk of higher cholesterol, diabetes risk, and heart disease risk. It's showing us why PCOS is actually a whole body condition. The researchers even developed a methylation marker model that showed high accuracy in making a diagnosis. Now, we're not at the point yet where you can just walk into a clinic and ask for DNA methylation to be tested in PCOS. But it does hint at a world where we are able to diagnose PCOS using these molecular markers. How we treat PCOS is changing too. The 2023 guidelines made some significant shifts. If you're dealing with infertility in PCOS, Letrozole is now the first-line recommended treatment to induce ovulation. This is replacing clomiphene citrate, or Clomid, which was the go-to for many years. The research has shown that Letrozole is more effective and has better outcomes. So if you're trying to conceive and your doctor is defaulting to Clomid, you can discuss this with them. But here's the biggest shift, and this one applies to everyone with PCOS. Lifestyle modification is now the primary first-line management for all women with PCOS. Diet, exercise, stress management, all of these are no longer nice-to-haves or add-ons. They are foundational. This is the most exciting to me because for a long time, they were thought of as nice-to-haves or things that you kind of add in at the end of a consultation, throwaway lines to say, oh, maybe you should also consider this in managing PCOS. This shift towards lifestyle medicine is exciting to me. But before you panic thinking that there's some kind of complicated regimen that you need to be following to the T, here's the good news. The evidence shows that a variety of approaches can actually work. This speaks to something called bio-individuality, which means that what works for you may not necessarily work for somebody else. So what actually matters is finding something that fits your preferences and your lifestyle. It's not about perfection, and it's also not about a one-size-fits-all approach. This is about sustainable change, things that you can actually stick to to give you long-term results. And honestly, that's actually empowering. You can build an approach that's genuinely sustainable for you in the long term. So there you have it, 4 truths about PCOS that are fundamentally changing the way we understand and manage this condition. Let me bring this all together for you. Let's recap. We started with the assumption that most people make about PCOS, that it's a reproductive condition, something about irregular periods and cysts on your ovaries. But we now know that the research is telling us something fundamentally different. The polycystic part of PCOS is often misleading. You don't need cysts in order to be diagnosed. And even the definition of what counts as polycystic keeps evolving. This shifts our focus away from the ovaries and towards the underlying hormonal and metabolic dysfunction that's really driving this condition. Second, PCOS is a full-body systemic condition with serious metabolic and mental health implications. This isn't just a period problem, it's a major public health issue that requires comprehensive, lifelong care. Third, diagnosis is becoming more accessible. A simple AMH blood test can now replace invasive ultrasound for adults, removing barriers and making it easier for women to get the answers that they need. And fourth, we're understanding PCOS at the molecular level through epigenetics research, which is revealing why this condition affects our whole bodies. And critically, treatment recommendations have shifted. Letrozole is now first line for fertility, and lifestyle modifications are the foundation of care for everyone, with no single perfect approach. It's about finding what works for you. So if you have PCOS, or you think you have PCOS, I want you to take something away from this video. You deserve care that sees the whole picture. You deserve doctors that understand that this condition affects your entire body and your mental health, not just your reproductive system. You deserve to be screened, monitored, and supported across all the areas that PCOS impacts. And you also deserve to know that the science is progressing rapidly. What we know today is light years ahead of what we knew just 5 years ago. The good news is the guidelines are finally catching up, and the future of PCOS care is becoming more personalized, more holistic, and more hopeful. Now, if you found this video helpful, I'd really appreciate it if you hit the subscribe button so that this video can help more people who need this information. And if you know somebody who has PCOS that you think may find this video helpful, please go ahead and share it. The more women who understand what PCOS really is, the better equipped we will all be to advocate for the care that we deserve. And if you've been diagnosed with PCOS, I'd love to hear about your experience with the healthcare system so far. Does it reflect what we've spoken about today? Or has your experience been something completely different? And what questions do you still have? Let's keep this conversation going in the comments, because the more we talk about this, the more we'll normalize getting comprehensive care for PCOS. I'm Dr. Carmen, and I'll see you in the next video. Take care of yourself. Bye-bye.